Welcome to Lesson 3, Cardiac Magnetic Resonance, CMR, or Cardiac MRI. Cardiac magnetic resonance imaging, or CMR, is a cornerstone in the non-invasive evaluation of suspected cardiac amyloidosis. Thanks to its unmatched spatial resolution and detailed tissue characterization, CMR provides powerful diagnostic and prognostic insights in transthyretin cardiac amyloidosis. Unlike standard imaging techniques, CMR allows us to look beyond simple wall thickness and directly assess the myocardium's internal structure. It helps differentiate ATTR-CM from other forms of hypertrophic cardiomyopathy with a high degree of confidence. Traditionally, amyloid cardiomyopathy was thought to manifest as symmetric, concentric thickening of the heart walls. However, more recent CMR studies have challenged this paradigm. In patients with ATTR-CM, we often see asymmetrical septal hypertrophy, mimicking patterns more commonly associated with hypertrophic cardiomyopathy. This finding is especially relevant when echocardiography alone suggests left ventricular hypertrophy but doesn't explain the clinical context. Without CMR, such cases can easily be misclassified. That's why it plays such a vital role, not just for diagnosis, but for understanding the true diversity of cardiac amyloidosis phenotypes. To visually reinforce what we've just covered, let's look at this example. This set of CMR images shows the four main morphological patterns seen in transthyretin cardiac amyloidosis. In the top left, we see asymmetric hypertrophy with a sigmoid septal contour, the most common pattern. Just below that is another form of asymmetric thickening, this time with a reverse septal contour, often mistaken for hypertrophic cardiomyopathy. Top right shows the classic symmetric concentric hypertrophy, which is still encountered but less frequently. And finally, bottom right, we see a case with no left ventricular hypertrophy, but subendocardial changes are still evident on tissue characterization. The key takeaway? ATTR-CM isn't morphologically uniform. Instead, it can mimic a range of phenotypes, from typical concentric hypertrophy to variants that closely resemble hypertrophic cardiomyopathy. CMR's tissue-level detail helps differentiate amyloidosis from mimics. The visual cues, like septal contour and hypertrophy distribution, can make all the difference in early, accurate diagnosis. One of the most powerful tools in cardiac magnetic resonance imaging, particularly for amyloidosis, is late gadolinium enhancement, or LGE. In transthyretin cardiac amyloidosis, LGE offers a non-invasive window into the pattern and extent of amyloid infiltration across the myocardial wall. As seen here, the process typically begins with no enhancement, then progresses to subendocardial LGE, and finally reaches a stage of transmural LGE, where the entire wall is involved. This progression reflects the underlying biology. Amyloid deposits begin near the endocardium and spread outward toward the epicardium. Alongside this, there's a corresponding increase in native T1 values and extracellular volume, ECV, both of which signal expanding interstitial space and fibrosis. Let's look at how this appears in actual patients. Top row, a patient with no LGE, normal native T1, and a low ECV, suggestive of minimal myocardial involvement. Middle row, now subendocardial LGE appears with borderline T1 values and a modest rise in ECV. Bottom row, in this patient we see transmural LGE, marked elevation in native T1, and a striking 63% ECV, consistent with advanced amyloid infiltration. These correlations help us visualize disease burden at a glance, moving us beyond simple wall thickness and into tissue-level diagnosis. Improvements in imaging techniques, like phase-sensitive inversion recovery, or PSIR, have dramatically increased the reliability of LGE in amyloidosis, especially where gadolinium kinetics are altered by abnormal tissue composition. In fact, pooled data shows LGE imaging achieves a sensitivity of 85% and specificity of 92% in diagnosing cardiac amyloidosis. But here's something interesting. Even though transmural LGE suggests deeper amyloid involvement, studies show no consistent survival difference between patients with subendocardial versus transmural patterns. This tells us that the pattern itself reflects phenotype, not necessarily prognosis. That's why it's critical to combine LGE with quantitative mapping tools like native T1 and ECV. Together they provide a multidimensional view: diagnostic, prognostic, and actionable. In clinical practice, these imaging markers can even eliminate the need for a biopsy, particularly in patients with systemic amyloidosis and classic imaging findings. Key takeaways. LGE patterns help visualize amyloid infiltration and correlate with disease severity. Transmural enhancement, high T1 and elevated ECV indicate advanced myocardial involvement. CMR helps monitor disease progression through serial imaging markers. And most importantly, this combination empowers earlier diagnosis, reduces misclassification, and enhances treatment decisions. In this section, we'll explore how two advanced cardiac MRI techniques, T1 mapping and ECV quantification, are transforming our ability to detect, stage, and monitor transthyretin cardiac amyloidosis. These tools allow us to go beyond structure, to measure tissue composition, amyloid burden, and even treatment response with precision. Native T1 mapping. T1 mapping captures how myocardial tissue relaxes after magnetization without using contrast. In patients with ATTR-CM, native T1 values are elevated due to amyloid deposits and interstitial expansion. This is especially helpful early in disease, even before LGE appears. That makes it a powerful tool in early diagnosis. The Schmolli sequence, for example, has shown over 90% sensitivity and specificity in detecting cardiac amyloidosis. But keep in mind, native T1 reflects both intra- and extracellular compartments, and it can vary depending on scanner type. So while it's highly sensitive, it's best interpreted alongside other markers. Now take a look at this side-by-side comparison. What you're seeing are short-axis Schmolli native T1 color maps on the top row and their corresponding LGE images just below. On the far left, we've got a normal subject. Notice the predominance of green on the T1 map, which reflects healthy myocardial tissue. Next to it, in the HCM panel, the T1 map shows patchy areas of elevated T1, red, especially within the thickened septum. In the myocarditis case, things get really interesting. The white arrow points to epicardial LGE, which aligns perfectly with the adjacent region of elevated native T1. This is a classic example of inflammation. And finally, the amyloidosis case. Here you can see diffuse and extensive red throughout the myocardium on the T1 map, indicating uniformly high native T1 values, which is typical for ATTR or AL cardiac amyloidosis. Schmolli, or shortened modified Look-Locker inversion recovery, is the sequence used here, and it gives us powerful, reproducible tissue characterization without even needing contrast. Extracellular volume, ECV mapping. ECV, by contrast, is derived from pre- and post-contrast T1 values adjusted for hematocrit. It gives a direct estimate of interstitial expansion, and therefore amyloid load. In ATTR-CM, higher ECV values correlate with worse outcomes. As shown here, patients with ECV greater than or equal to 0.58 had significantly lower survival than those below that threshold. This makes ECV a key prognostic biomarker, and one that applies to both hereditary and wild-type ATTR. What about treatment response? T1 and ECV can be tracked over time to assess therapeutic effect. The on-screen figure shows native T1 and extracellular volume, ECV, before and after 12 months of tafamidis treatment. 3 Tesla cardiac magnetic resonance imaging showing native T1 mapping A before and B after tafamidis. There was no obvious worsening of native T1 value, 1387 to 1356 ms. ECV C before and D after tafamidis also showed no significant worsening, 42.0 to 40.4%. This demonstrates how CMR not only aids diagnosis, but also plays a central role in longitudinal care. Importantly, T1 and ECV changes may precede structural abnormalities, enabling earlier detection, particularly in mutation carriers. Together with LGE, T2 mapping and perfusion imaging, they contribute to a multiparametric approach covering amyloid burden, fibrosis, edema, and ischemia. This comprehensive profile allows for nuanced diagnosis and personalized disease monitoring. As our understanding of cardiac amyloidosis deepens, so does the role of advanced cardiovascular magnetic resonance, or CMR, in its evaluation. While structural changes are important, a ATTR-CM is more than just wall thickening. To truly assess disease biology, we need to look deeper at inflammation, edema, and microvascular function. That's where T2 mapping and perfusion imaging come in. T2 mapping, a window into myocardial edema. T2 mapping measures myocardial water content, essentially how wet the heart muscle is. In light chain AL amyloidosis, T2 values are often elevated, indicating edema or inflammation. And while this finding is less common in ATTR-CM, early studies suggest it can occur in select patients, especially during active disease or treatment response. Elevated T2 has also been linked to worse prognosis, making it a potential biomarker of risk and a target for therapeutic monitoring. So, while not routine yet, T2 mapping is becoming a valuable piece of the puzzle, especially in cases with uncertain progression or atypical features. Next, let's look at vasodilator stress perfusion, CMR. This technique assesses how well blood flows through the heart muscle under stress. In a ATTR-CM, it often reveals something unique: endocardial to epicardial perfusion gradients. These gradients are due to interstitial expansion and capillary compression, which reduce blood flow even when the coronary arteries appear normal. This microvascular dysfunction is more than just an imaging detail. It's linked to impaired oxygen delivery, fatigue, and disease progression in ATTR-CM. To fully appreciate the complexity of transthyretin cardiac amyloidosis, we need more than one imaging technique. This is where multiparametric CMR steps in. By integrating cine imaging, LGE, native T1, T2 mapping, and ECV mapping, we gain a holistic view of the heart, capturing not just structure, but the entire pathological fingerprint of amyloid infiltration. What does this look like in practice? Take a look at this composite image. Here we see representative scans from a patient with cardiac AL amyloidosis, top row, a patient with cardiac ATTR amyloidosis, middle row, and a healthy volunteer, bottom row. From left to right we move through. Cine images at end diastole capturing wall thickness and chamber size. LGE imaging revealing the location and extent of myocardial scarring. Native T1 maps sensitive to tissue composition changes. T2 maps highlighting edema and inflammation. ECV maps directly quantifying amyloid burden. The contrast is striking. In AL amyloidosis, top row, we see diffuse subendocardial LGE, very high native T1 and T2, markedly elevated ECV. This reflects aggressive infiltration, edema, and inflammation, hallmarks of AL pathology. In ATTR-CM, middle row, LGE is typically transmural. Native T1 and ECV are elevated, but T2 is usually normal or mildly increased. The imaging suggests chronic interstitial expansion without overt edema, a distinct pattern helping differentiate ATTR from AL. In the healthy volunteer, bottom row, no LGE. Normal native T1 and T2, low ECV. This represents the baseline myocardial state, clean, uninfiltrated, and free of disease. So what's the takeaway? By layering these imaging biomarkers, LGE shows a scar and infiltration. Native T1 reveals subtle tissue changes. T2 points to active edema or inflammation. ECV quantifies amyloid burden. Together, they enable precise phenotyping, diagnosis, risk assessment, and treatment monitoring, even in the earlier stages of disease. This is modern imaging in action, data-rich, non-invasive, and clinically transformative. When it comes to diagnosing and monitoring cardiac amyloidosis, consistency is key. That's why standardized cardiovascular magnetic resonance, CMR, protocols are essential. They ensure that imaging data are accurate, reproducible, and clinically actionable across different centres and follow-up visits. The most widely accepted framework for this comes from the 2021 International Expert Consensus, jointly supported by societies such as SCMR and ASNC. Let's walk through what this protocol entails. CMR in cardiac amyloidosis is about more than just wall thickness. Interpretation must combine structural, functional, and tissue-specific findings in a structured report. This involves both quantitative thresholds and qualitative hallmarks. Here are the key components every CMR report should include. Let's start with left ventricular function and morphology. 1. Left ventricular function. When assessing left ventricular function, what we typically observe in cardiac amyloidosis is biventricular long axis impairment. However, what stands out is a relative sparing of apical function. Now, even though the ejection fraction might appear normal, and this is key, don't be misled. In advanced cases, a reduction in ejection fraction can occur, although that's less common. So always keep an eye on function, even when EF seems preserved. Reporting this parameter is required. 2. Left ventricular wall thickness. Now, increased left ventricular wall thickness is one of the hallmark signs. What you're seeing is a 4-chamber cine sequence, a dynamic view that captures the heart's movement in real time. This particular scan demonstrates 2 hallmark features of cardiac amyloidosis: biventricular hypertrophy, thickening of both the left and right ventricles, and biatrial enlargement, which reflects the chronic pressure overload often caused by stiff, amyloid-infiltrated ventricles. Such imaging findings, especially when combined with clinical data and biomarker levels, are essential for early detection, staging, and monitoring of disease progression. Thickness is considered abnormal if it exceeds the upper limit of normal based on sex-specific lab standards. And importantly, if the relative wall thickness is greater than 0.42 centimeters, that further supports the diagnosis. But context is crucial. Increased LV wall thickness is more suggestive of amyloidosis when you also have normal or low QRS voltages on ECG, or if there's increased right ventricular wall thickness. Typically, the thickening is concentric, but in a TTR amyloidosis, it can be asymmetric. So again, this is a required component in your report. Next up is stroke volume index. A value less than 35 milliliters per square meter is considered low. While this isn't a highly specific finding, it's still suggestive of cardiac amyloidosis, and it's something to include in your assessment. This measure is required as well. 4. Left ventricular mass. Let's talk about myocardial mass. An LV mass of at least 91 grams per square meter for men or 78 grams per square meter for women is considered elevated. When measuring, make sure you include the papillary muscles as part of that calculation. This quantifies not just the myocardial mass, but also reflects the amyloid burden, which can be quite significant in these patients. So yes, this too is required in your reporting. 5. Atrial size and function based on Simpson's method. Moving on to the atria, both size and function are relevant here. Let's break this down. A left atrial volume greater than 163 milliliters in men and more than 131 in women is considered increased. A right atrial volume above 85 milliliters per square meter is also abnormal. And in terms of function, if you see atrial function reduced to less than 29% in men or less than 35% in women, that's another supporting clue. These findings might be non-specific, but they're still important. They can offer insight into the patient's risk for stroke or systemic embolism, and they support the overall diagnosis. Again, required. Lastly, don't overlook pericardial effusion. While not specific on its own, when you see it alongside other signs, especially if the left ventricular ejection fraction is preserved, it raises your suspicion significantly. So even though it might look subtle, include it in your report. This is also a required parameter. So just to summarize, every parameter we've discussed here, from ventricular function and wall thickness to atrial measurements and pericardial findings, is required in your report when evaluating for cardiac amyloidosis via cardiac MRI. Each element contributes a piece to the puzzle. When assessed together, they can guide diagnosis, stratify risk, and influence management decisions. Let's move on to amyloid imaging. This section focuses on specific MRI techniques designed to detect and characterize amyloid infiltration in the myocardium. These tools are particularly valuable because the findings are often subtle on cine imaging alone, and amyloidosis may be missed without contrast-enhanced techniques. 1. LGE imaging, late gadolinium enhancement. LG is central to cardiac MRI evaluation for amyloidosis. Key abnormal patterns include diffuse subendocardial or patchy enhancement, difficulty achieving myocardial nulling across inversion times, and dark blood pool signals. These findings strongly suggest cardiac amyloid infiltration. Standard magnitude inversion recovery imaging is not ideal due to challenges in selecting optimal inversion time, TI, in amyloid patients. Instead, phase-sensitive inversion recovery, PSIR, is preferred for more reliable tissue contrast. Here's an example of a cardiac magnetic resonance inversion recovery sequence in a patient with amyloidosis. Notice the failure to null the myocardium, unlike in healthy tissue, where the myocardium should appear darker than the blood pool at the correct inversion time. Quantifying LGE is not recommended for routine clinical practice, given the diffuse, non-territorial nature of enhancement. Still, clearly identifying and describing the LGE pattern, especially when diffuse or subendocardial, is essential. Let's talk about amyloid quantitation. So far, we've discussed how to identify amyloid infiltration through function, morphology, LGE, and signal suppression. But quantitation adds something new. It gives us a measurable biomarker that can reflect disease burden, progression, and even response to therapy. We'll focus on two techniques, native T1 mapping and ECV estimation, both of which use T1 mapping technology. 1. Native T1 mapping, pre-contrast. First, we have native T1 mapping, performed before contrast administration. Here, we're looking for an abnormally elevated T1 value. But the exact cutoff depends on the sequence used, typically moly or schmoly, as well as the field strength of the magnet, 1.5T versus 3T. That means your institution needs to define its own reference ranges based on local calibration. What's important here is that elevated native T1 reflects interstitial expansion, most often from amyloid infiltration, even without using gadolinium. That makes it an incredibly useful tool in patients with renal dysfunction, where gadolinium use might be contraindicated. While it doesn't replace contrast-based techniques, it strongly supports the diagnosis and should be included when possible. Recommended. 2. T1 mapping post-contrast, ECV estimation. Next is post-contrast T1 mapping, which allows you to calculate extracellular volume, or ECV. In cardiac amyloidosis, ECV values above 0.40 are highly suggestive of disease. That's because amyloid deposits significantly expand the extracellular space, which is exactly what ECV quantifies. There are two protocols you can use to capture this. Option A, one pre-contrast and one post-contrast measurement, typically around 15 minutes after injection. This is recommended for routine clinical use. Option B, one pre-contrast and three post-contrast measurements at 5, 15, and 25 minutes post-injection. This extended protocol gives more accuracy, but is optional, used mostly in research or high-detail clinical evaluations. Both approaches aim to capture the dynamic contrast behavior of amyloid-laden myocardium, and ECV gives a quantifiable marker that correlates with disease stage and prognosis. Because ECV reflects actual amyloid burden, it can also help monitor therapeutic response, especially in patients undergoing disease-modifying treatment. Recommended for option A, optional for option B. Summary: amyloid quantitation tools. Here's what to include when quantifying amyloid infiltration. Native T1 mapping, pre-contrast. Abnormally high T1, values based on moly-schmoly sequence and field strength. No contrast needed. Reflects interstitial expansion. Recommended. T1 mapping post-contrast for ECV estimation. ECV greater than 0.40 is highly suggestive of amyloidosis. Reflects extracellular amyloid volume. Option A, one pre and one post-contrast at 15 minutes, recommended. Option B, one pre and three post-contrast, 5, 15, and 25 minutes, optional. These tools are especially valuable when integrated with LGE findings, wall thickness, and functional markers, giving a complete tissue characterization profile of cardiac amyloidosis. With quantitation, you're no longer just describing morphology, you're measuring pathology. And in diseases like amyloidosis, where early diagnosis can change the clinical trajectory, these values are more than numbers, they're indicators of treatment potential. Now that you've gathered and evaluated all the CMR parameters, from LV function and morphology to LGE patterns, signal suppression, and T1 mapping, your next step is to summarize and categorize your findings into a clear diagnostic interpretation. Overall interpretation of CMR findings. Each study should conclude with an overall impression that categorizes the findings as one of the following. Not suggestive. This means all findings are within normal limits. You should see normal LV wall thickness, normal LV mass, no ventricular LGE, and normal atrial size. In such cases, cardiac amyloidosis is unlikely. Required. Strongly suggestive. These are the classic CMR features of cardiac amyloidosis. You'll see multiple abnormalities, including increased LV wall thickness, increased LV mass, biatrial enlargement, diffuse or global LGE pattern, difficulty achieving myocardial nulling, ECV greater than 0.40, small pericardial and/or pleural effusions. When these appear together, the diagnosis becomes highly probable. Required. Equivocal. This category is for studies that don't clearly fit into either of the above. Findings may be borderline, mixed, or atypical. In such cases, additional testing or correlation with clinical and laboratory findings is essential. Required. Contextualizing the CMR findings. Your interpretation should always be made in the context of prior clinical evaluation, including ECG, lab results, and nuclear imaging when available. Recommended. For instance, if prior lab tests show elevated free light chains or abnormal immunofixation, you may lean toward AL amyloidosis. On the other hand, if a technetium-based bone scan, like 99-MTC-PYP, shows myocardial uptake with no evidence of plasma cell dyscrasia, ATTR-amyloidosis becomes more likely. Follow-up recommendations. Now let's talk about what to recommend next, especially when the CMR is strongly suggestive of amyloidosis. Here's the key point. CMR cannot distinguish AL from a TTR cardiac amyloidosis, so further evaluation is necessary. To exclude AL light chain amyloidosis, recommend evaluation for plasma cell dyscrasia. This includes serum and urine immunofixation, serum free light chain FLC assay. These tests help identify monoclonal protein production. To exclude a TTR amyloidosis, recommend nuclear imaging with one of the following radiotracers: 99-MTC-PYP, 99-MTC-DPD, or 99-MTC-HMDP. Importantly, endomyocardial biopsy is often not needed when you have strongly suggestive CMR findings, a histologically confirmed systemic amyloidosis, or a diagnostic nuclear scan result. So always tailor your recommendations based on the entire clinical picture. Recommended. At the end of your report, make sure you've done the following. Categorize the findings as not suggestive, strongly suggestive, or equivocal, interpreted the imaging in the clinical context, provided clear next steps for differentiating AL from ATR amyloidosis. By doing so, you not only support diagnostic clarity, you also guide efficient and targeted follow-up, reducing delays in what is often a time-sensitive diagnosis. Let's go through these case studies together with Dr. Mary.
Hello, everyone. In this case, we're reviewing CMR findings in a 73-year-old patient with transthyretin, a TTR, cardiac amyloidosis, confirmed via endomyocardial biopsy. Let's go image by image to understand the pathology and the diagnostic contribution of CMR. Here we see a T1 native map, and the findings are striking. There is global elevation of T1 values throughout the entire left ventricular wall, from the septum to the lateral segments, consistent with extensive interstitial amyloid infiltration. This diffuse pattern of elevated native T1 is a hallmark of amyloidosis and reflects expansion of the extracellular space. In ATTR, these values are typically higher than normal reference ranges, often exceeding 1100 milliseconds at 1.5 t, depending on the magnet and protocol. Next, we have LGE images in two-chamber short-axis, panel B, and long-axis, panel C views. Notice the diffuse transmural enhancement of the LV myocardium, along with subendocardial involvement of the right ventricle, a pattern strongly suggestive of ATTR cardiac amyloidosis. This enhancement is non-ischemic in distribution, sparing no coronary territory and difficult to null, one of the classic imaging signatures of amyloid infiltration. The involvement of both ventricles also correlates with more advanced disease. Finally, the bullseye plot in panel D quantifies regional native T1 values across the myocardial segments. Every segment shows uniformly elevated T1 times, further reinforcing the diagnosis of a diffuse infiltrative cardiomyopathy. This visual representation helps confirm that the disease is not regional or patchy, but rather global, aligning with the clinical picture of a TTR amyloidosis. In summary, this case beautifully illustrates how multiparametric CMR, including native T1 mapping and LGE, provides a comprehensive tissue characterization that aligns with the pathology of ATTR cardiac amyloidosis. Let's move to another case. We're reviewing CMR findings in a 75-year-old male patient with cardiac amyloidosis, ATTR wild type. Let's go image by image to understand the pathology and the diagnostic contribution of CMR. Fatigue, dyspnea on exertion. Non-obstructive hypertrophic cardiomyopathy with reduced ejection fraction, EF, in cardiac echo. History of bilateral carpal tunnel syndrome. The patient had a heart rate of 68 beats per minute and a body surface area of 2.03 square meters. Cine images. T2. Black blood and stir imaging revealed thickening of the interventricular septum, orange measurement greater than 20 millimeters, and the interatrial septum, blue measurement approximately 8 millimeters. T2 ratio was less than 1.9. A T2 ratio of greater than or equal to is considered abnormal. Minimal pericardial effusion, blue arrowhead. Look locker? Images sorted by acquisition time. On close inspection, the myocardium passes through the 0 point before the blood pool. Usually this is the other way around. Late gadolinium enhancement, LGE. It is conspicuous that the blood pool has an even darker signal than the nulled myocardium, not only on the inversion recovery gradient echo images but also on the PSIR image. This is due to high myocardial gadolinium uptake and fast blood washout referred to as abnormal blood pool gadolinium kinetics. There is subendocardial late gadolinium enhancement in a non-coronary arterial distribution, red arrowheads, in mid-ventricular and basal segments, and faint transmural enhancement of the septal and inferior basal segments, red arrows. T1 mapping native and post-contrast. Obviously increased native T1 here measured in the basal inferoseptal segment, z-score of 6.3. Native T1 measured in other segments ranged from 1170 to 1250 milliseconds. Decreased post-contrast T1. Massively increased extracellular volume, calculated at 60% or higher. This case illustrates and reviews the MR imaging features of cardiac amyloidosis. Left ventricular hypertrophy, increased indexed mass, thickened interatrial septum, faster myocardial nulling than the blood pool, dark blood pool and subendocardial late gadolinium enhancement, LGE, in a non-coronary distribution with transmural pattern, and high values in native T1 and extracellular volume, ECV. Higher values in extracellular volume, ECV, wall thickness, and mass have been reported for ATTR amyloidosis, whereas higher native T1 values and higher T2 values, the latter as a biomarker for myocardial edema, 7 have been reported for cardiac AL amyloidosis. This is why a TTR is in favor over AL amyloidosis in this case. An endomyocardial biopsy obtained about 6 months after the cardiac MRI revealed cardiac interstitial ATTR amyloidosis. Subsequent genotyping led to the diagnosis of wild-type ATTR amyloidosis.
Thanks, Dr. Mary. Now let's wrap up this module by reviewing steps 3 and 4 of the cardiac amyloidosis diagnostic algorithm, where the key focus shifts to subtype confirmation and genetic classification. At this stage, we've already completed myocardial phosphorus scintigraphy, evaluated the Perugini score, and determined whether a monoclonal protein is present. Now our next moves depend on the combination of these initial findings. Let's walk through it step by step, using the chart you see on screen. Step 3. Diagnostic stratification, confirming the amyloid type. Once amyloidosis is suspected or confirmed through imaging or clinical signs, we proceed to clarify what kind of amyloid we're dealing with: AL, wild-type ATTR, or hereditary ATTR. This process relies on 3 critical tools. 1. Tissue biopsy. If imaging results are ambiguous or the patient has a known plasma cell dyscrasia, a biopsy is essential. Endomyocardial biopsy, EMB, remains the gold standard, offering nearly 100% sensitivity when properly performed. Extracardiac biopsies, such as fat pad, nerve, or salivary gland, may also be used but are less sensitive for cardiac ATTR, particularly in wild-type forms. In cases of bilateral carpal tunnel syndrome, biopsies from tenosynovial tissue during surgery can reveal early ATTR deposits. When Congo red staining is positive, we move to amyloid typing, ideally via mass spectrometry, to distinguish AL from ATTR. 2. Genetic testing. If the imaging and lab profile are consistent with ATTR and no monoclonal protein is present, genetic testing becomes the next key step. This determines if the patient has hereditary hATTR or wild-type WT-ATTR amyloidosis. Genotyping identifies mutations like Val30Met, associated with neuropathy, or Val122-IL, cardiac predominant, especially in individuals of African descent. Genetic testing also informs family counseling and long-term management for at-risk relatives. 3. Cardiac MRI-CMR. As you've learned throughout this module, CMR is central to subtype classification, revealing characteristic patterns of wall thickening, gadolinium uptake, ECV, and T1 values. It can suggest a TTR versus AL phenotypes based on transmural versus subendocardial LGE and help quantify amyloid burden using ECV thresholds greater than 0.40. CMR also helps avoid unnecessary biopsy in cases with clearly ATTR type imaging and no monoclonal protein. Step 4. Confirm subtype and recommend follow-up. Once subtype is confirmed, Step 4 focuses on final diagnostic labeling and ongoing management. If AL amyloidosis is identified, the patient must be referred for hematologic treatment, typically chemotherapy or stem cell transplant. If a ATTR-CM is diagnosed, wild-type ATTR often affects elderly men and is managed with transthyretin stabilizers like tafamidis. Hereditary ATTR requires not only treatment, but also genetic counseling and screening for family members. Crucially, all patients, regardless of subtype, should enter a multidisciplinary care model. Ongoing cardiac imaging, biomarker surveillance, and neurologic evaluations are essential to track disease progression and treatment efficacy. In summary, Step 3 integrates biopsy, genetic testing, and CMR to stratify and subtype cardiac amyloidosis. Step 4 confirms the diagnosis and initiates subtype-specific follow-up, including family screening and personalized therapy. Together, these steps transition the process from diagnostic discovery to definitive diagnosis and long-term management. When you follow this framework, supported by high-quality imaging, accurate lab work, and patient-centered care, you're positioned to deliver early, accurate, and impactful treatment for patients with cardiac amyloidosis. In the next module, we'll move into the last step of the diagnostic algorithm, where we'll focus on the staging, treatment, and follow-up. I'll see you there.